The triggers that we would usually have in terms of frontline therapies and changing the frontline therapies, certainly we continue these medications on an ongoing basis so long as the patients are deriving clinical benefit as defined by a lack of progression, no new lesions, no growth of the existing lesions or very slow growth of new lesions, and also a question of tolerability. So we want to have that all to be true. Whereas if we notice that the disease was growing in some sort of way or patients were having difficulty from a tolerability standpoint, then that certainly would trigger us to think about switching treatments. Right now, in terms of what we would do as second line treatment, a lot of this is based off of what treatments that they've had in the past and how they did, on the treatments. In this patient in particular, they were started on a single agent TKI because they had favorable risk disease, and kind of from a time course standpoint, combined immunotherapy was not necessarily an option. However, they had an outstanding response to a single agent TKI. Typically speaking, a long-term responder to a single agent TKI is about 18 months, and the patient, certainly exceeded that, and went on for more than double what the median progression-free survival was on a single agent TKI, really suggesting that there's probably a strong VEGF component to their disease. And we take that into consideration about whether or not to stick with additional VEGF targeted therapy or thinking about switching to some sort of IO containing regimen. So in thinking about second line therapy, the options for this patient after having been on a single agent TKI include a single agent checkpoint inhibitor, such as nivolumab, could consider cabozantinib as monotherapy, could consider lenvatinib plus everolimus as a combination therapy targeting both the mTOR and VEGF signaling pathways, or even other second-line TKI therapies.